Angela.
Thanks, Kathy, and thanks to the whole consortium for this invitation to be the first one presenting in this little seminar slot and present this work to describe this new electronic health record research resource for research on over 54 million people for England. So you've just seen this figure, but just a reminder, the new resource, it's been established to enable whole population research on COVID-19 and cardiovascular disease. It comprises of the linked person-level electronic health records, importantly from primary care, hospital episodes, death registry and community dispensing data, along with COVID-19 lab test results. And as Kathy just alluded to, there's further enrichment planned from the other data resources listed here. So these separate data sets, they've all been linked from across the different healthcare settings by NHS Digital and are accessible by approved researchers within the new trusted research environment. So over the next few slides, I'll summarise the features of this resource through describing a cohort of the 54 million people who we identified to be alive on the 1st of January in 2020 and who are registered with an NHS general practitioner. And this cohort comprises of 96% of the population in England. So first of all, these are the characteristics of the linked cohort. 51% of the individuals are female and 14% are aged 70 years or older. And the mean age of females is 41.6 years and the mean age of males is 40 years. Importantly, by linking and combining the person-level records from across the primary care and hospital admissions, we were able to gather ethnicity information from almost 95% of people in the cohort. 63% of that information came only from the primary care, whereas 92% were recorded in hospital admissions. And this is really just illustrating the strength and wealth in combining the person-level data from across the resources to define these key characteristics. On this slide, we further show the importance of the linking the person-level data from the healthcare settings to ascertain cardiovascular events. So here, this is a Venn diagram showing how the incident, stroke and TIA events came from the different healthcare settings. So amongst those people without a previous record of stroke or TIA, we observed nearly 100,000 people with a first ever incident, stroke or TIA between the 1st of January and the 31st of October 2020, of which you can see that 30% were recorded only in primary care and were not found in the hospital admission data or death registry data. Probably really because we've included TIA in the definition here of this endpoint. But similarly, we can see that 4%, only 4% were recorded only in the death registry records. Let's move over to the incident myocardial infarction. So again, amongst those with no prior MI, we observed around 63,000 events in the same follow-up time. But this time we see 8% were recorded only in primary care, but now 12% recorded only in death registry records. Now, I think what will be really interesting for a bit of a future investigation will be to see how these proportions of the incident cases from 2020 differ from those in the pre-pandemic years. And we might see some differences there in how people presented with these cardiovascular endpoints. So here we have a similar figure, but this time showing the 19 diagnosis, again within the same follow-up period of January to October last year. And we observed close to 1 million people with a COVID-19 diagnosis, which concords with the Public Health England official statistics reports in the same period of time. And what we can see, if I was to pull out key things, we can see here that this overlap here, I really hope that you can see my arrow, I think that you can. There's around 58% of the diagnoses were recorded both in primary care and the COVID-19 lab test data, whereas you can see that there's a 15% of the COVID-19 diagnoses were reported only in primary care. Again, I'm using this to really illustrate the importance of combining data from across the different healthcare settings to get a very clear picture of disease endpoints and diagnosis. Now, I should just say, the reason why there is this discrepancy or why there are these differences between the healthcare settings is really because in the code lists used to define COVID-19, say in primary care, where SNOMED codes were used, or in hospital episodes and death records, where ICD-10 codes were used, then we used code lists which reflected a clinical or epidemiological diagnosis, but without a confirmed test result. So that's why they're not all overlapping. So on this next slide, I show the COVID-19 diagnosis reported from those different healthcare settings, but this time by sex, age, and ethnicity. And I've got a couple of slides with plots like this, so I'll just explain what each bar is representing. So let's take this bit here. So each bar represents the proportion of the defined group with a COVID-19 diagnosis reported in that healthcare setting. For example, we've got 1.5% of females here with a COVID-19 diagnosis reported in the lab test data results, in comparison to 1.3% of males. And actually, we do see that whereas females are more likely to have a COVID-19 diagnosis in their primary care records or in COVID lab test data, it reverses for hospital admissions and on death registry records, where men tend to have a higher proportion of diagnosis. In a kind of a similar fashion, actually what we see is that it's younger participants, or those under the age of 70, who are more likely to have a COVID-19 diagnosis reported in primary care or in the lab test data. But actually, when we move on to more onto hospital admissions and death, which reflects more severity COVID cases, we can see that a higher proportion of over 70s in comparison to under 70-year-olds are more likely to have records there. We also see a higher proportion of Asian and Asian British people have a COVID-19 diagnosis, both in the primary care and in the COVID-19 lab test results. However, this difference in comparison to the other ethnicities doesn't remain when you start looking at the records only from the hospital admissions and from the death data. And in fact, if we zoomed in here, it's white people who have a higher proportion of white people have COVID-19 on their death registry records. However, it's massively important to note that these are all unadjusted comparisons, and it's very likely that there are differences in the age distributions between the ethnic groups, which is probably driving these comparisons. So further, motivating further research in this area. And as I've said before, one of the key benefits of conducting research on whole country cohorts really is the ability to conduct research across a wider spectrum of kind of scientific questions. So we've talked about minority subpopulations, but also in disease subtypes and comorbidities, which are otherwise not possible in smaller subsets. So here we're showing people with a previous diagnosis of stroke and TIA. I think that's this one here. Yep, stroke and TIA here, MI here, obesity here, and diabetes. And again, it's the same kind of format of the figures. What we're showing is that people with a previous history of stroke, MI, obesity, or diabetes are more likely to have a COVID-19 diagnosis recorded across all healthcare settings. But actually, we see a comparatively higher proportion in the more severe settings of hospital or death registrations. And actually, I've just put the numbers here so that we can start thinking about actually how many deaths are we seeing in these small groups of individuals. And we see around 10,000 deaths amongst those with a previous history of MI, TIA and stroke and obesity. And I think it's more so for diabetes. Again, really giving us the numbers to examine these relationships at greater detail. So finally, just as a summary, this is the first ever provision for research of linked national electronic health records from across 96% of people in England. The resource provides linked person level data from all the different healthcare settings And we've shown that it's imperative for defining cardiovascular disease outcomes, COVID-19 diagnosis, and for maximising the completeness of key characteristics. By including data from almost the entire population of England, it's inclusive of all age groups, ethnicities, geographical locations, and socioeconomic, health and personal characteristics, and will enable statistically powerful research on really large numbers, which I hope really excites you all, it excites me. The resource is accessible by approved researchers through the secure TRE, and initially is supporting, as Kathy said before, of COVID-19 and cardiovascular disease research, but will also benefit other future research initiatives. And finally, you know, I must stress what a team effort this is. It's been a joy to be part of the CVD COVID UK consortium. And I've listed some key people, in particular Rachel, Sam, Jennifer, Samantha and Venicia, who've been instrumental in performing some of the analysis shown here. And also to Alvina for producing some really nice figures from our more messy, raw ones which we produced. So we're really thankful to everyone listed there. And of course to the Consortium Coordination Centre, in particular Reuven and Lynn, and our patient and public advisory panel, and of course NHS Digital. And that's it. Thank you very much for listening.
Thanks, Angela. That was really terrific and really exciting to see some of the data that looks more exciting in some of your plots than in tables, and it really kind of brings out some of the statistical power issues that I think are a key advantage of this resource. It means that we can use it to study rarer outcomes, disease subtypes, and lots of different characteristics, and fully inclusively, of course, because the whole population is included. And just to emphasize as well that we obviously have great partnerships with the devolved nations as well, which means that we can move rapidly towards a UK-wide approach. So all very exciting. So, questions for Angela. If I can encourage you to, I won't be able to see everyone, so to use the electronic hand raise function if you're able to, but wave frantically if you can't, and hopefully one of the team can butt in and let me know that you've got something you want to say. I'm just quickly surveying what we've got. It's great to see so many people. There's nearly 60 people joined us today at extremely short notice, so that's wonderful. Including we've got a special guest appearance from Alex Markham, who's the co-chair of our oversight committee. Alex, you're very welcome. Thank you for joining us. So, well, let's allow people to continue